The intraoperative phase begins when the patient rolls into the OR and it ends when they leave the OR. We're going to talk about the roles and responsibilities of the OR team members, nursing priorities, anesthesia, airway management, and risks and complications. This is to give you an idea of what a surgical suite might look like. There are 3 zones. The unrestricted zone is going to be where street clothes are permitted, traffic flow is not monitored, and temperature of this zone doesn't matter. You have your nurses stationed in this area, usually depending on the facility. The semi-restricted zone is where we start worrying more about asepsis. Movement should be unidirectional, so they're going from clean to dirty. You don't want anybody going from dirty areas into clean areas. You're going to have these substerile areas adjacent to the OR suites in the semi-restricted zone. Anyone in this area should be wearing surgical scrubs and have their hair covered. So when you go into the peri-op realm, you will wear hospital scrubs. So you come in your street clothes, you check out your hospital scrubs, and you give them back to them to launder at the end of the day. The restricted zone is where temperature is going to be monitored. Everything is under positive pressure to prevent contamination, and the OR suites are within this where the patient is actually having surgery. This has at least 15 air exchanges per hour to prevent mold growth and bacteria, and humidity has to be between 20 and 60% at all times. Here we have the Joint Commission Universal Protocol again. Today we're going to talk about performing the timeout. So the timeout happens right before first cut. The procedure cannot be started until all questions and concerns are resolved, so patient cannot be put under until they know exactly what's happening, they don't have any more questions. The timeout, like I said, is right before the first cut. Designated member of the team starts the timeout and it's standardized. So usually the person who's going to start the timeout is the surgeon in most of my experiences. So we are going to have all the immediate members of the procedure team, so anybody in the OR at that time. So you have the surgeon, the anesthesiologist, the circulating nurse, the OR techs, and anybody else, including students that may be in the room. So you actively communicate during the timeout. So the surgeon will say, I am Dr. So-and-so, I am performing surgery today on patient's name, what he's doing. In the room with me I have, and we go around the room and everybody states their name and their purpose for being there. So at the very least, we have to identify the right patient, the right site, and the procedure. When there are 2 or more procedures happening for the same patient, if the person performing the procedure changes, they do another timeout before that person begins. The completion of the timeout is documented by the OR nurse, the circulating nurse, and the type and amount of documentation will depend on your facility policy. Here you have that comprehensive surgical checklist again, made by those perioperative governing organizations. In the intraoperative phase, we are looking at the timeout and the sign-out portion. So this is making sure that everything is done properly for the timeout and it's documented. And then before the patient leaves the OR, we are debriefing what are key concerns for recovery and management of this patient so that the OR nurse can pass that on to the PACU nurse. Here we're taking a look at the surgical team members. You have a sterile team and you have a non-sterile team. Sterile team is going to include the surgeon, any surgical assistants, and then your scrub nurse, which these days they use a surgical tech. That's the person in charge of all the tools and making sure that the doctor gets the right one and that everything stays sterile. So if you see scrub nurse anywhere, their responsibility is to make sure everything stays sterile. They make sure that if the doctor drops their hands below waist level, they're letting them know so they can re-scrub. If there's a broken glove anywhere and nobody is noticing, the scrub nurse is keeping eyes on that thing to make sure that it gets fixed so nothing ends up not sterile in the operating area. So non-sterile members in the OR are going to be your anesthesia provider, your circulating nurse, any unlicensed assistive personnel, so your PCAs, your PCTs, CNAs, whatever you want call them at your facility, and then your OR director, coordinator, or manager. Now, non-sterile means they did not scrub in. They don't have to have sterile gloves on. They are in the room. They still have a mask on. They still have their hair covered. They still have surgical scrubs. They just don't have to be completely sterile. They are not working in the surgery hands-on. Okay, so priorities of the OR nurse. Risk for infection. So perioperative asepsis is the OR nurse's responsibility. They are making sure the surgical scrub is completed, that surgical attire is correct. Everybody's wearing their mask, their hair covered, their gown if they're wearing one, their gloves. They're watching the sterile setup, making sure the sterile fields stay sterile, making sure the tools stay sterile. They're watching traffic flow and making sure nobody is in the surgical suite that shouldn't be there. They are making sure that skin prep is completed, so the doctor does the iodine or chlorhexidine or whatever wipe down beforehand, before first cut. And antibiotic prophylaxis. So they are making sure they find out from the pre-op nurse if that antibiotic was given within 1 hour prior to that first cut. Another priority of the OR nurse is preoperative assessment. So they are not completing the pre-op assessment themselves. That's done by the pre-op nurse, but that pre-op assessment at minimum has to accomplish 4 goals. It has to determine the patient's level of knowledge related to the planned surgery, any complications and interventions such as insertion of an indwelling catheter, and providing education as appropriate. This time allows the patient to voice any specific concerns or questions regarding the procedure. Second goal is to confirm that informed consent for this surgical procedure has been obtained. Any discussions needed are done and explained. The procedure is explained to the patient in terms they can understand and they can teach back. The third goal is to determine the patient's level of anxiety so that we can support his or her management of preoperative fears and post-op concerns. So this is done with open discussion, discussing the causes of anxiety like fear of death or disability or pain, family issues like childcare, as in our earlier case study, fear of rejection if they're doing a transplant, all those things. And then the fourth goal is to obtain that relevant information about the patient. So the intra-op nurse is his or her priority to ensure that the pre-op assessment is complete and on the charts. Another priority of the OR nurse is impaired tissue integrity and any injury related to positioning. So we know our patients stay in these surgical positions sometimes for a very long time. And patients at Cancer Treatment Center who would be in surgery for over 12 hours in one spot. So we have to make sure that we are watching and that their skin isn't breaking down and that we can offload as much as possible during that surgical procedure. You have the image here that shows you all the different surgical positions that could be. So figure sitting in one of those positions for 8 to 12 hours could be horrible when you wake up. So your patient is at risk for pressure injury. They use positioning devices and like sandbags, pillows, all kinds of things to try to offload a little bit of the pressure as much as they can without obstructing the surgeon's work. Patient transfer is also part of this. Injury related to positioning. So like I said in class, you have your transfer and it's not super gentle. So the OR nurse is making sure that that the patient doesn't get injured during that process. Another priority of the OR nurse is altered body temperature, making sure that patient stays warm enough in the very cold environment. So we're using warm blankets, we're using warming blankets and bear huggers to keep that patient warm. You can see in the picture there a very futuristic bear hugger. I haven't seen one that wraps around the patient and stays on quite that well. If you've ever used a bear hugger, you know that once you turn that on, it will fly off. So usually we have to put a blanket over the top to keep it in place. I have never seen a bear hugger that has a window in it for your procedure to happen through, but that would be pretty cool if we could have that. So yes, bear huggers are used a little less frequently just because you have to have access to that procedure area. Some other priorities of the OR nurse in the intraoperative phase are preventing that wrong site, wrong procedure, wrong person surgery, prevention of any retained surgical items, prevention of DVT, fire prevention. Yes, there are a lot of fire risks in the OR, and then making sure that they cover that comprehensive surgical checklist. All right, so on to anesthesia. There are 4 types. We have general anesthesia, where we put the patient completely under. Regional anesthesia, where we're just going to affect one region of the body. That's your epidurals and everything like that. We have local anesthetics, so that's just one area. Like lidocaine, for example, you're going to numb just that area. And then we have monitored sedation, also known as conscious sedation. So that's like your Versed, where your patient is awake and can communicate with you, but they have an amnesic effect. So they're not going to remember what happened. There are 4 different stages of anesthesia. This is on page 653 of your ATI book for more details too. Stage 1 is analgesia and sedation and relaxation. Stage 2 is excitement and delirium. Stage 3 is operative anesthesia or surgical anesthesia. And stage 4 is danger or respiratory arrest. So you can look at that a little closer in your ATI book. So general anesthesia is what the layperson calls being put to sleep. It is a reversible unconscious state. There are a few different ways we can do this with gases like nitrous oxide. We have IV agents like barbiturates, benzos, opioids. We have propofol, ketamine, and any sedative hypnotics that we might use for that. And then we have paralytics like succinylcholine, which we call SUX, vecuronium, rocuronium. If you are using a paralytic, your patient has to be intubated and ventilated. So these patients will be on a vent because you are paralyzing them so that you can perform your surgery without them moving. Any anesthesia done without paralytics, less invasive airway management can be used. If anybody has ever heard of an LMA, that's a little mask basically like you put on an ambu bag, but it has the tube connected to it, and that just sits in the back of the throat and holds the tongue out of the way, and then ventilation or oxygen is sent in that way. So we have 5 stages in the sequence of general anesthesia. The first stage is induction. These are important for you to know. Induction is when you obtain IV access and administer sedation. This stage is complete when the patient becomes apneic. So when the patient stops breathing, that's when we go to intubate. We do rapid sequence intubation usually, and so you give your pain medication, your sedative, and then your paralytic all on top of each other without flushing in between, and then you wait for the patient to stop moving, stop breathing, and then you place the tube. So that brings us to stage 2, intubation. This is when you place and secure the airway. So safety-wise, you have to always consider when you're intubating to have suction available. We talked about aspiration risk. If that patient does begin to vomit during the process, you have to have that suction available so that you can suction that out and try to prevent it from getting into the lungs. The third stage is maintenance. So this is while we're maintaining the patient using balanced anesthesia. The fourth stage is emergence. So we are suctioning in this stage to avoid aspiration. We are reversing their medications, waking them up. And once they are breathing on their own and following commands, that's when we extubate and take the tube out. So that's in that emergence stage. The final stage is recovery, and that's when we transport to PACU or the ICU, and the patient is monitored until stable. So you can see this information in your F.A. Davis book. It's table 16.3 on page 311, and it will also be included in those charts to know. Here we have complications associated with general anesthesia, so you can have hypoxia. Your patient can end up with respiratory and cardiovascular dysfunction. They could have hypotension or hypertension, fluid and electrolyte imbalances, residual muscle paralysis after the paralytics wear off. They could have neurological problems such as dementia, prolonged awakening, so it's taking them longer to wake up, or paresthesias. And then malignant hyperthermia, which we will talk about in more detail right now. Malignant hyperthermia is a medical emergency. If this does not get treated quickly, your patient will die. So triggering agent causes sustained muscular contraction. So a triggering agent can be any volatile gas other than nitrous oxide or succinylcholine. Succinylcholine is not used as a paralytic as often as other drugs like vecuronium and rocuronium now, because we have found it is linked to higher cases of malignant hyperthermia. So family history also puts the patient at greater risk of malignant hyperthermia. That's why it's important for that pre-op history to determine what family history is. The patient ends up with sustained muscular contractions that result in signs of hypermetabolism. So that's acidosis, tachycardia, hypercarbia, glycolysis, hypoxemia, and hyperthermia. The reaction usually begins to occur soon after exposure, but it has been known to be delayed until the patient is in the recovery area. So PACU nurses need to be aware of what anesthesia was given to their patients, because it can happen up to 24 hours after anesthesia was given. The most specific sign of malignant hyperthermia is skeletal muscle rigidity, but the first sign noted by anesthesia or nursing staff is usually unexplained tachycardia. So if your patient is doing fine and all of a sudden their heart rate jumps up and none of their other vitals change, we're going to be worried that malignant hyperthermia is happening. So for the anesthesiologist, hypercarbia is usually the most sensitive indicator of potential malignant hyperthermia. So they have a carbon dioxide monitor on the patient, and they will see that start to rise quickly. Myoglobinuria is another early sign. The patient's urine turns from dark amber to brown. So if the circulating nurse is sitting at that desk documenting and they look down and realize that the urine in the Foley bag is brown, they're going to let the doctor know, hey, we might have some myoglobinuria happening. Hyperthermia is a classic sign of malignant hyperthermia, but it is usually a late sign. So like I said earlier, without quick and appropriate action, this patient can die. So how do we treat this? We have to cool the patient, and we use a medication called dantrolene. So we need to cool the patient quickly. So we're going to take off all the blankets, any drapes that are on them. We can infuse iced normal saline into their IVs. We can put ice packs around them. If they have an NG tube, we can put cold water into there, so cool down their belly. If it happens during the operation, they can actually do a cold body cavity lavage. So they'll run cool water into the area. Like say they have the chest open, they can run cool water in there, or actually just put ice into the chest cavity. Here you can see those signs and symptoms of malignant hyperthermia separated into early signs and late signs. So the first things you're going to see are the unexplained increase in end-tidal CO2, the unexplained tachycardia or an arrhythmia. They'll have that masseter muscle rigidity, so the anesthesiologist might notice that their jaw gets clenched on the tube. Generalized flushing, skin is warm to the touch. They can have hyperkalemia, so we'll see on the EKG, if their potassium goes up, you're going to see peak T waves. And then that generalized muscle rigidity, so their body will start to cramp up. If they get to the point where they are hyperthermic or hypoxemic, or they start to get cyanotic, then we're in trouble. Hopefully at that point you've already got that team, the malignant hyperthermia team, on the case, and you've got dantrolene to give to your patient. Regional anesthesia is a local anesthetic used to block or anesthetize a nerve or nerve fibers. The different types are going to be your spinal, epidural, caudal, and nerve blocks. Spinal, epidural, and caudal are all along the spine. It just goes into a different space. So spinal is going to be in that spinal space. The epidural is in the epidural space along the spinal cord. And then caudal is in the coccyx area, still in the epidural space. A nerve block can be used for an arm or a leg. For instance, if you're doing a carpal tunnel surgery, they can do a nerve block that just numbs the arm. Spinal medication is injected into the spinal canal, like I said, or it's called the intrathecal space, usually in the lower back or lumbar region. This injection can last for several hours, and it can also be given continuously via a catheter. I had patients that had like epidural pain management, so they would have a little machine that little catheter would stay in place there. So with spinal anesthesia, your patient can end up with a headache. This can also happen with epidural, so spinal or epidural. You want to make sure that you keep the head of the patient's bed flat afterwards to avoid a headache. This headache happens because of cerebrospinal fluid or CSF leakage through that little the injection point. This headache usually resolves in 1 to 3 days, but there can be times where it lasts longer. So then they go in and try to do a blood patch with the patient's own blood just to patch that spot so the CSF is no longer leaking and that headache will get better. So local anesthetics are your lidocaine, your novocaine, bupivacaine, those things. So like at the dentist, what they use when they do drilling on your teeth or fillings. We have to be careful with those because higher concentrations will not only inhibit pain, but also muscle control. So if you have a whole lot, they give you extra novocaine, for example, at the dentist because you were still feeling the work they were doing. Then you start to lose that feeling in your face and you lose the use of the muscles. Adverse reactions can happen with overdosage or rapid absorption or hypersensitivity. Mild reactions include hives, itching, and rash. Severe reactions can be an acute anaphylactic reaction. Lidocaine is used for paracentesis or central line insertion. They'll just inject it in the area to numb it up. Novocaine is at the dentist, like I said. Cocaine is actually used, fun fact, for nasal surgery, or in the ICU. We have used it when a patient has consistent nosebleeds and nothing we try is working. So it vasoconstricts. Monitored anesthesia care, you get that maintenance of consciousness. It elevates the pain threshold. You get enhanced cooperation because the patient is awake with a little degree of amnesia. It minimally varies for the vital signs, and they have a quick and safe return to activities of daily living. So usually that is used benzodiazepines like diazepam or midazolam, which is your Versed, with narcotics like fentanyl or Dilaudid. So you use that, and signs are posted outside the OR so staff is aware that the patient is awake, so that conversation can be kept to a minimum. So that decreases anxiety of the patient and also allows us to get through and get their needs and comfort addressed easily. All right, so the things that increase the risk of complication with anesthesia: a history of smoking. As we talked about in our pre-op period, smoking can increase respiratory depression with anesthesia. Previous reaction to anesthesia or family history of reaction, that increases our patient's risk. Any medication or latex allergies, herbal remedies or CAM or OTC medications, any cardiac disease, respiratory disease, gastric contents gives us that danger of aspiration, as you know, and then alcohol or substance abuse can affect the use of our anesthesia. Airway management is the process of protecting and ensuring adequate oxygenation and ventilation during an operative procedure. This is not only important for patients receiving general anesthesia, it should be considered with any kind of anesthesia. We need to make sure that that patient is protecting their airway, even if they are not intubated. We are watching for this, or if they're not getting general anesthesia. Airway compromise can be caused by a relaxation of the soft tissues of the oropharynx. So the relaxed effect can create an occlusion of the trachea or trigger a laryngospasm. So the airway can also be compromised in patients who present with anatomical abnormalities, like a small mouth, a short neck, inability to open the mouth fully, obesity, or facial or cervical injuries. Laryngospasm is a reflexive and prolonged closure of the vocal folds in response to a trigger. So this usually happens during anesthesia induction and intubation or extubation. So stimulating the airway with those airway devices and secretions ends up causing the larynx to spasm, and then it'll just close. Bronchial intubation is when the ET tube is passed below the carina, so we put it in too far, it ends up in the mainstem bronchi, and then you're hyperinflating the intubated lung, so, and possibly collapsing the opposite lung, because when it goes down into that mainstem, you're only forcing air into one lung. Tracheal and esophageal perforation. This can occur during intubation if excessive force is applied or as a complication of the use of a stylet or other stiff intubation assisting devices. So basically they hit the side of the trachea or the esophagus and they cut it, so perforate it. Aspiration, if the patient regurgitates, stomach contents end up in the lung, that can end up in airway obstruction or pneumonia. So common airway devices used in the OR are going to be that AT tube, that LMA I talked about, which is the little mask that they put into the back of the throat, or a face mask. Here we have the nursing diagnoses related to the intraoperative phase. We've talked about most of these already, so just for your knowledge there, if you know these nursing diagnoses, it will be easier for you to critically think about issues that come up with your patient. So the nursing management during the intraoperative process includes your assessment. So this is making sure your OR consent is signed and on the chart, making sure the patient is correctly positioned. You monitor the donning of OR attire, making sure that the sterile members are properly clothed and that the non-sterile members are also properly clothed. Everybody's wearing a mask and hair covering. Making sure that supplies are available, everything we need for that procedure. Checking the fluid and instruments for temperature and making sure that flashed instruments have cooled off and we don't burn our patient with those. Actions or interventions for our intraoperative nurses, making sure we perform the timeout, we facilitate that if it doesn't happen. Performing the equipment safety checks, utilizing sterile technique and overseeing that process, making sure everybody uses it. Assisting the anesthesia provider during intubation, properly grounding the patient as indicated, like we talked about with that electrocautery. We have to ground our patients in the OR. Keeping patient safety belt in place if possible, depending on where the procedure is taking place. Applying support hose and SCDs, keeping the patient warm, maintaining that sterile field, accurately recording the number of sponges and sharps. We have to make sure that the number of sponges and sharps that were in the room to begin with are in the room after the patient is closed. We need to make sure we don't leave any of those in there. Accurately measuring any irrigation fluid. We need to know what goes in and what comes out of our patient. Making sure the OR doors stay closed, and then keeping the hallways clear of equipment in case there is an emergency. We want to make sure that we have room for everybody to run in and take care of the problem. And that last part of our intraoperative phase nursing management is the education. So we're making sure the patient knows what to expect, and we are keeping the family, if they are waiting, updated at the beginning of surgery and every 2 hours until it is done, because the best way to help our patient and their families cope is education.